machine learning and data science component of DataCon LA 2021. We're very pleased to present our next speaker, Dr. Kristen Honey. I am Ron Lee, and my co-host is Renroy Das. We will be monitoring the chat tab as well as Q&A. And so if you have any comments, please put them in the chat. You can also just announce yourselves. This is a community after all. And questions will be handled after Dr. Honey's talk. Now, the title of Dr. Honey's talk is Data-Driven Innovation in the Federal Government. That in itself is a mouthful for everything it represents. It's an exciting time to be running data innovations at the intersection of public health crises, government response, and the best of private industry coming together to solve America's most pressing public health issues. No doubt, Dr. Honey's InnovationX team resides in the U.S. Department of Health and Human Services, Office of Assistant Secretary for Health. The InnovationX team tackles complex challenges by harnessing the power of open data, open science, open source, citizen science, crowdsourcing, prizes, challenges, and innovative public-private partnerships for public health. Dr. Honey has worked in the White House across 3 administrations, advising the White House National Security Council and the HHS Chief Information Officer on big data sharing, governance, analysis, and predictive analytics with artificial intelligence machine learning. In collaboration with the CIO, she established the Office of the Chief Data Officer and co-founded the Data Governance Board to implement the Open Government Data Act, which became law with the Foundations for Evidence-Based Policymaking Act. She transformed the interagency Open Data Community of Practice with data.gov from the Open Data Policy Guidance. In June 2018, Dr. Honey transitioned to HHS and the immediate office of the Secretary. When the COVID-19 pandemic hit in 2020, Dr. Honey worked with the HHS Chief Information Officer to establish the HHS Office of the Chief Data Officer. As HHS's Chief Data Scientist and Executive Director of InnovationX, she has led the $25 million Kidney X Innovation Accelerator, founded the HHS Lyme Innovation Initiative, established LymeX, a $25 million public partnership with the Stephen and Alexandra Cohen Foundation, and most recently launched Pandemic X. Dr. Honey earned her PhD at Stanford University in the Emmett Interdisciplinary Program in the Environment and Resources School of Earth Sciences, while simultaneously earning a PhD minor in Civil and Environmental Engineering from Stanford. She holds an MA in Environmental Studies from the University of California, Santa Cruz, and a BA in Human Biology with honors from Stanford. In her spare time, Kristen enjoys yoga, hiking, jogging, sailing, scuba diving, skiing, traveling, and holistic health work for Lyme disease, while also having the special ability to hypnotize lobsters to stand on their heads. She is a proud Mainer. Go Maine! Thank you very much. Let's all welcome Dr. Kristen Honey to the stage.
Thanks so much, Ron. Really, really appreciate the intro and super excited to be here, DataCon LA. Thanks for everyone for watching and joining. If you have questions or thoughts, put them in the chat. Definitely want to answer whatever questions and have a discussion, however the crowd would like to take things. And thanks all for being here. So today is National Day of Civic Hacking. So I don't know how many of you are open data enthusiasts and participated in National Day of Civic Hacking. I think we're in our 9th year. And it's very community driven, create real world value from data to solve local challenges, things that are important to the community. And this is my first DataCon LA conference, but it sounds like it's all community driven, all community led. And that is exactly the space that my team at Health and Human Services, or HHS, what we try to do, have it people-centered, human-centered, and iterate, co-create solutions together. So all of us the past 2 years have had our lives radically disrupted by the COVID pandemic. It is so complex and multifaceted. It has touched all aspects of our lives. Obviously, our workforce, kids in school or not in school, public health, economy, you name it. Every part of our lives have been impacted by COVID, which means every single one of us can be part of the solution. The multifaceted challenge is going to be made better and ultimately solved because of all of us working together, all hands on deck. Whether you're in industry, whether you're in academia, nonprofit, part of the open data movement, part of the maker movement, part of your local community as organizers, local government, we all have to roll up our sleeves, offer what we can, contribute our expertise, and together we'll be part of the solution. So my team in the COVID response really has focused on data and data-driven solutions. In the beginning of the pandemic, I was leading partnerships, public-private partnerships, and innovation. And when the pandemic hit, instantly pivoted, changed my day-to-day job because we needed all the informaticists and data scientists that we could to understand the COVID pandemic and this novel virus that humanity didn't even know about until the end of 2019. We needed to understand it super quickly, develop diagnostics. We were starting at ground zero, and we had to go from 0 to 100 before we even knew what we were dealing with. So overnight in March 2020, February 2020, my day job went from partnerships, innovation to data. And the first project I was assigned to was interagency data sharing. And how can we have the biggest bang for the buck with the copious amounts of data that exist at HHS and other agencies like Department of Defense? Think of all the service members, all the military electronic health records and the data in there. Veterans Affairs, all of the veterans medical records and the largest hospital system in the world. The federal government has a wealth of information and data. So how could we extract maximum value from that? From HHS headquarters, we thought really what we want to do is take our high value data and put it onto supercomputers, because the United States has some of the world's fastest computers. And if we could move our big amounts of data that we think have the secrets to unlock with this novel virus, that will accelerate scientific discoveries, it'll lead to scientific breakthroughs. We will all have a better idea of what we're dealing with and how to hopefully control and mitigate this pandemic. So the first project, we called it the Insights Partnership, COVID-19 Insights Partnership. And it was Department of Defense, DOD, Department of Energy, DOE, HHS, Health and Human Services, and VA. And all of us worked together to very quickly move the valuable data sets to Oak Ridge National Lab supercomputers. This enabled high performance computing, and then from all that data, unleash the power of artificial intelligence, machine learning, all these emerging technologies. So in the early few months, if you saw all the papers coming out, the breakthroughs of how certain demographics were at greater risk, how certain pre-existing conditions were greater risk or less risk. A lot of that research came out of this Insights Partnership, where big amounts of data were put on supercomputers, and then AI just cranked through to see what patterns and complexities in this rapidly moving pandemic existed. So in, I guess about in April, then things pivoted. We had all our data on the supercomputers. What's next? And what we needed to do was to build a data sharing platform, a secure ecosystem that would give us a holistic view of the entire pandemic. Data from not just government, but also academia, industry, all sectors that had sources of information and visibility into the pandemic in different ways. How can we ingest that, securely share it, and then from that, find insights, transform that raw data into understanding and knowledge, and then that can drive action. From that knowledge, then we can make data-driven decisions or guide evidence-based policymaking. So that was a huge undertaking. And in a collaboration with the HHS Chief Information Officer and many other colleagues, we stood up this system called HHS Protect. And HHS Protect is our COVID data sharing platform. It launched in April 2020, and it was a real-time place where decision makers could go and see what's happening. What are the latest trends? You didn't have to get a report daily. The people on the front lines, state government, HHS, CDC, whoever you could get access and had access, there are thousands of people, many thousands with licenses, could go in and ask the questions they want, see the real-time maps and infographics on what's happening with the pandemic relevant to them, and then that would guide their decisions. So a very distributed approach to sharing near real-time information. Very quickly after that launch in April, we realized, wow, we need to do this as transparently as possible. We want these platforms to be built on the foundations of security, privacy, transparency, and trust. And so how can you build trust? And we thought trust is consistency over time. So let's keep pushing out the data consistently as we possibly can. And then let's pull back the curtain and show, let the public see as much of the data as we could. So in early summer 2020, we launched the HHS Protect Public Data Hub. And this is the public-facing version where you can see the maps, the infographics, the analyses. So HHS Protect Public. And it pushed out that information in digestible ways for the world to see. And then all of the information underlying that, we're pushing to healthdata.gov. So there's a lot of COVID open data that anyone can access and that people can analyze themselves, and that all pushed to healthdata.gov. Some of you may be using data.gov, which is the home of all federal government open data, and that's okay, because every single day, data.gov scrapes the information from healthdata.gov, and you'll find it in both places. So that was our push of, we had to first start COVID data sharing, then we had to really do that intentionally in the public for the people, of the people, by the people, for the people. This is your data, and let's push those data assets out there to the world, and then make that machine readable and easily discoverable on healthdata.gov and data.gov. So that was probably the first 6 months, maybe 9 months of the pandemic. And after these data sharing enterprise-wide systems, ecosystems existed, then I focused on diagnostics. And why diagnostics data? I mean, there are many different elements to the pandemic. It could be a lot of people were working on vaccines. A lot of people were working on optimizing clinical trials. Others were analyzing the genetics and epigenetics and all the omics and publishing papers on that front. So why diagnostics? And from the data space, we thought of diagnostics as the foundational information that we need to know. If our government doesn't know who's positive, who's negative, when and where, we don't have visibility in the pandemic. We don't know where areas are at risk, where an outbreak is happening, and that information is necessary to contain it as early as possible. And that foundational data about who's positive, who's negative, and the testing data, those results feeds into every other decision in the pandemic. So I wanted to really focus on the diagnostics data. Now, early in the pandemic, as many of you probably remember, it was hard to get tests. In the very beginning, we didn't even have tests. This was a novel virus. Scientists had to develop diagnostic tests to confirm whether or not people had COVID-19. Once those were developed, you had to go into a doctor's office or a hospital or a laboratory setting to get a test, and they were limited. The government and public health is really, really good at capturing that data. So if you went to your doctor and you get your test done, there's whole plumbing and infrastructure that takes those results and moves them, shares the relevant information to the states, to public health. So HHS, CDC, all the decision makers have the information they need about outbreaks. So if you go to a hospital, doctor's office, laboratory setting, that plumbing is great. With COVID, when testing was limited, the US government said, let's buy 150 million rapid tests, those 15-minute antigen tests, and get them out to people on the ground as quickly as possible. So 150 million rapid antigen tests went out to all 50 states. And if you have taken any of those tests at home, you can buy them now over the counter. It's sort of like taking a pregnancy test where, you get one line is negative, 2 lines is positive, but there's no way we do not collect that data, or there was no pre-existing infrastructure to collect that data. So after 150 million of these tests were shipped out, we thought, oh my gosh, as more time goes by and more tests are being done outside of a laboratory setting, outside of a doctor's office, we're going to be increasingly losing visibility into the pandemic. It's great to get tests to as many places as we can, but how can we also ensure we have visibility? So my team and I focused on the non-lab testing. So if you got tested at a drive-through site, if you got tested at a school, at a nursing home, how can we capture that data? And after all those tests went out, we realized people on the front lines are so busy and overworked. We didn't want to add more to their already, overloaded plates. So let's meet people where they're at. Let's figure out what apps they're already using. Some states had built their own systems. Some school districts have their own systems. Many industry and private apps and websites existed for reporting it. So rather than telling people use this app or use this tool, we thought, let's support optionality. Let's go meet people where they're at, whatever tools they're using, and then we'll create the plumbing to ingest that data, harmonize it, and route it where it needs to go. And this will be another source of information for pandemic decision makers that augments the conventional laboratory testing. So we really had a big push on supporting all the different types of testing that are done outside of hospitals in a setting. Now, all of this work today has really moved into a much bigger modernization initiative and a digital modernization, public health modernization initiative that CDC is leading. And so this work is not just going to be for COVID, but it's going to be up-leveling and improving how public health is done for all future pandemics and all future operations. So in this rapid moving of how do we capture this data, how do we ingest things, we also didn't have all the answers. We had a lot of smart collaborators, great people in government, everyone giving it their all, great people outside of government, public-private partnerships. It was all sectors working together, but these issues are thorny and complex. And as the FDA was approving more and more diagnostic tests on the market, the ecosystem was getting more complicated because each COVID diagnostic test is slightly different. If you go to a drugstore today, you can buy different brands and they all use different technologies and report differently. So in federal government, we realized that we have this moment of time where we can get ahead of the curve and we can say, these are the required data standards and data elements, and we want diagnostic manufacturers to build for and send their information to us. So that was our first thought was, we need data standards, we need data elements. Let's get those out. So those data elements, those required data elements for non-lab tests exist, and federal government put it out. And that was a good milestone forward. And then we quickly realized, as with any industry, data standards are only as good as their adoption. If industry and the manufacturers don't use the data standards, are they doing any of us any good? Probably not. So we realized we had to really push for their adoption. And how could we do that? And our thinking was, this is so complex and we don't have all the answers. Let's put out a call to action and let's ask the American public what your solutions are. What would you do to ingest all these different diagnostic tools that are coming on the market? How would you capture the data from the tests that are soon to be sold at drugstores? Because back in summer 2020, when we were doing this, we knew that a lot of these technologies would be approved for at-home use or over-the-counter use without a prescription. And so it would be even harder to capture them, although when we started the project, they didn't quite exist. So we knew the more time that went by, the more complex it would get, the harder it would get. So we thought, let's open it up with a call to action, put a spotlight on the challenge that we're facing, share the data standards, and ask the public, what would you do? So we launched a COVID-19 at Anywhere Diagnostics Designathon. And this Designathon was an innovation sprint, a month-long innovation sprint. And we took a crowdsourcing platform and we wanted to harness the power of the crowd, harness the wisdom of the collective experiences out there. And so from the data element of the non-lab test, we framed the problem, put a spotlight on it and said, solve with us, create solutions with us. What are your best ideas for federal government to, as seamlessly and easily as possible, ingest data from all these heterogeneous sources, all the different places diagnostic tests are being done in non-laboratory settings? And not only how do we ingest it, how can we harmonize it? How can we securely route it to the places it needs to go? And then what are the tools, digital tools, that we can use to extract the maximum value and understanding from that data? And so we put out that call. We thought maybe a couple hundred people would be interested in this diagnostics design-a-thon. We thought maybe we'd get 10 good ideas. We called the ideas capstone projects. And what we encouraged people to do on the crowdsourcing platform was to create a profile, share their expertise, find a team, sort of like if you've ever gone to a hackathon and you find a team, share ideas, you prototype it, and then at the end of this 4-week-long iterative sprint where people were exchanging ideas, we were throughout the month doing some programming where the solvers, the developers, the people working with on the crowdsourcing platform could speak to subject matter experts, data experts, federal government regulators. And after this month, people would submit their capstone projects, their proposed solutions. And like I said, we were hoping to get 10. We got over 30 submissions from over about 1,000 people were engaged. 700 participated in the design-a-thon part. We were blown away. Over 30 projects submitted, or capstone projects, and the quality of them so far exceeded anything we imagined. And then we thought, this is so good, we need to do a phase 2. The power of the crowd, the American public, our global response, this truly was all hands on deck. So then we decided to do a phase 2 of the design-a-thon. And phase 2 of the design-a-thon is what we called the COVID-19 TopX Technology Sprint. So we had a month-long innovation sprint that sort of down-selected it because judges looked at all the capstone projects, and of the 30 plus submissions, they picked 15 winners. They said, wow, these 15 ideas really could be game-changing and really make a difference. And so the judges picked 15 to join HHS in a full technology build cycle where industry and the teams would develop the digital tools that they proposed. Now, because it was a crowdsourcing innovation sprint, we wanted the public to also pick its favorite solution. And so we had what we called the People's Choice winner, and the people would vote on their favorite solutions. And so a 16th winning team went on to the tech sprint. And this COVID-19 TopX Technology Sprint ended up being a great success. It was an 8-week tech cycle, a fast-paced build cycle. And it was modeled after President Obama's White House and a methodology that came out of the Obama White House that they called the Opportunity Project, or TOP for short. And these TOP tech sprints were inspired by hackathons. So, many of you have probably participated in hackathons. Today, National Day of Civic Hacking. A lot of people around the country, around the world, are hacking on open data, creating digital tools and solutions, creating real world value from data to solve problems that are important to them in the community. But the challenge, or one thing we saw with hackathons, is that you get awesome people together. Ideas are exchanged, new connections are made, people who wouldn't otherwise meet share ideas, disciplines collide, and great potential emerges. But often those ideas stop there. Like, how do you build those ideas to actually be tools and products that are sustained long term? So the Obama White House said, what if we did a hackathon over time? So you still get the teams and everyone together, but instead of it being a day or a weekend, you could do it over a 3-month period. And you have sustained engagement. And in the beginning, people share their ideas. And then by the end of it, they actually have a full tool fully developed. So that was the model we wanted to use. But for our COVID-19 TopX Sprint, we made 2 major changes. One, instead of doing a 12 to 14 weeks, so a 3 to 4 month sprint, we said, COVID, we need solutions yesterday. It is so rapidly moving and so fast paced. Time is of the essence. It is more important to have solutions tomorrow. and than it is, 2 months from now, 3 months from now. So let's not have perfect be the enemy of good. Let's start acting, and let's condense the build cycle. So we shortened a 3 to 4 month period into 8 weeks, and we ran an entire technology sprint, the full cycle, with the designathon, the winning designathon teams, in a condensed, faster paced one, because COVID was such a rapidly moving pandemic, and we needed these digital solutions now. The second thing we did that was different with our COVID-19 TopX Tech Sprint is that we defaulted to radical transparency. And what do I mean by that? Everything we did in our TopX Sprint was in the open, from our office hours to the meetings with government experts, to connecting the teams to the data stewards, questions about how to implement the data standards. We had all of our meetings, all of everything in the open. And you can see that work on our crowdsourcing platform. It's waters.crowdicity.com, WATERS, so waters.crowdicity.com. And we did everything in the open because we realized that change and impact and success will only move at the speed of trust. And if the American public didn't trust our science, or didn't trust our government and trust our public health recommendations, they would not adopt them. And if we're going to solve this pandemic together, we absolutely need to build trust. So we pulled the curtains back. We wanted to demystify how HHS and how government operates and be fully transparent, radical transparency. So everyone, even if you weren't one of the TopX teams developing a digital tool, could witness and see the entire process for yourself. On the other side of that 8-week build cycle, we had, 12 different digital tools launched. So 16 teams began because it was 15 Designathon winning folks selected by judges. The People's Choice made 16. And then during the tech sprint, some of the teams merged and combined because they realized that each one of them had different parts of the solution. So they merged together to create even a more impactful solution. And many of those tools that came out the other side are on the market today. So you've probably heard of the IBM Digital Health Pass. Many venues, places are using it to check vaccination status, credentials, your public health certifications, for re-entering employment. If you're going into a concert and they have, or a bar and they have, certification. One of the tools that's out there, there are many, but the IBM Digital Health Pass was one of the teams that sprinted with us. We also had a group, LifePoint, and they're an aggregator of lots and lots of non-lab data from all different sources. And so they harmonized it and then created the plumbing so that could go to HHS Protect, our COVID data sharing platform, and public health could use that. There's UDO Test, which is another company that allows employers and individuals to connect with tests and get laboratory test access. So there are many tools that are out there in the market being used today, and even more, some of the foundational pieces of a lot of the tools that you're using for COVID information management from the individual side. But the whole idea of that was to ask the power of the crowd, what are your solutions? What would you do? And then encourage people to adopt the data elements for reporting, the data standards, federal data standards, and then get out of the way and let industry, let American ingenuity, let them run. And the beauty of these technology sprints that we did is that these digital tools and these solutions are not government solutions. They live outside in the marketplace. And so it's not up to us and government to long-term sustain them or maintain them, but rather academic groups and the teams that develop them, entrepreneurs, they're the ones who will continue to work on these. So the role of government was really coming up with the data standards, shining a light on the problem, combining people in ways or connecting people that they wouldn't otherwise, providing access to data experts, the data stewards, fielding questions, and then be part of the solution, but also harness the power of all different sectors. Now, another common theme in our office that we use a lot is partnerships. And when you know something is going to work, when you know something needs a lot of change and not just incremental improvements, but transformative impact, partnerships can be one way to be an accelerator, a force multiplier to go big. So we've done that with this TopX Sprint. It was a lot of lightweight collaboration, but in other sectors, we've done large-scale partnerships. And the most recent one is actually somewhat inspired by COVID. We have a $25 million public-private partnership for Lyme disease. And we call it the LymeX Innovation Accelerator. And how's that connected to COVID? Well, diagnostics for Lyme disease have not really changed in 40 years. It's an ELISA and a Western blot test. That technology's been around since the 80s. I don't know about you, but the phone I use, the TV I watch, pretty different. Most of you probably weren't even born in the 80s. So it's definitely outdated. It needs transformative science and technologies to have the next generation of diagnostics. Now with COVID, all hands on deck and science accelerated diagnostic capabilities, how much of those billions of dollars invested in COVID research and diagnostics work might apply to improve diagnostics for other diseases? We think at HHS that there are probably a lot of other diseases that will benefit. So we formed a public-private partnership for Lyme disease, and we're in the process, or just recently announced, the LymeX Diagnostic Moonshot, and we're very optimistic that many of the scientific breakthroughs, many of the technical breakthroughs will also drastically advance diagnostic technologies for other diseases. And we're hoping that this partnership, putting a spotlight on the need to move the field forward for Lyme disease diagnostics, will take some of the lessons learned, some of the insights from COVID, and move that field forward as well. So common theme in all of this is that we in government unlock the data, we put a spotlight on it, pull together whatever disciplines, whatever resources, whatever partnerships and tools might be needed to solve that and co-create solutions with a broad variety of groups. So I'll end before we go into the Q&A by just saying, how can we all work together, and how can you get involved? I mean, many of you are already scrubbed in, working at the local level, working in your communities on the COVID response. There's so many different ways to contribute. If you're interested in collaborating with HHS and federal government, and you are an entrepreneur working at a startup in biotech, interested in health equity, we just launched, HHS just launched in the past week, this accelerator called PandemicX. So if you're a biotech startup, you're an entrepreneur, and you're interested in doing an accelerator, so taking your idea and moving it to market, this PandemicX accelerator is designed to do exactly that. The focus of it will be on health equity and how do we bridge the health equity gaps that COVID-19 has exacerbated. So if you're interested in PandemicX, we're doing it in collaboration with Mass Challenge. So go visit masschallenge.org or Google HHS PandemicX, and we'd love to collaborate with you, and maybe we'll see you in that first cohort of PandemicX. Thank you.
Awesome, Dr. Kristen. It's awesome presentation, awesome talk. Let's go to Q&A. So the first question, how did you hear about DataCon LA?
How did I hear about DataCon LA? Great question. Someone in the Civic tech movement who used to work with US Digital Service and US Digital Response brought it to my attention. So I don't know if you know of US Digital Response, some of you might have worked on it, but in response to COVID, there was a call to action and a nonprofit formed asking people to lend their data science, design, whatever skills you could, and volunteers were matched with local, state, federal government that needed all the help. And thousands and thousands of volunteers have been matched with government needs. And so someone who was really plugged into the civic tech movement and has worked closely with the White House U.S. Digital Service and U.S. Digital Response, that nonprofit volunteer group, flagged this and said, this is a great community-driven data thing. Would love you to be a part, and I'm thrilled, and I'm really glad for the connection, and thank you for this opportunity.
Cool. Preet is asking, the Lyme disease is a great example of stagnancy in medical diagnosis. How can we detect other such examples? Is there an initiative in HHS to identify such areas of improvement?
That is a great question, and there's a huge need to have an enterprise-wide view for where can we have the biggest bang for the buck in disruptive innovation. Like, where's the market stagnation, sometimes for decades, that will affect large, communities and have a huge, big impact. Right now at HHS, the InnovationX team is doing that in collaboration with many other parts across the department. There's a whole new ARPA Health, so applied research development, so huge innovation in technology for health that President Biden is starting and is just getting off the ground. So I am very optimistic in the future that we will have much more rigorous, transparent, many, many more people, behind us doing that enterprise-wide view of where have things stagnated, where can we have the biggest impact. Yeah, huge need. We're doing it some, but there's a lot more we could be doing. And the president's budget, this new ARPA Health, will do exactly that. And you asked, how can we detect other examples? One other example is kidney care and dialysis. And dialysis really hasn't changed much since the 1970s. And the amount of money that we spend as taxpayers on dialysis and late-stage renal care is astronomical. And the quality of life for people who are on dialysis is really, really poor. So that's another area where the market stagnated, affects huge number of Americans, and the drain on the economy is huge. So we also have a KidneyX Innovation Accelerator. And again, it's sort of been ad hoc with our team recognizing it, but we're optimistic with this ARPA Health that there will be many more of these examples that will be addressed.
Next question from Chong. No doubt the US has many innovative technologies, but we are not doing well in response to COVID-19 pandemic. Many people refuse to wear face masks or to get vaccination. Is there any innovation in terms of the psychological and human aspect? As for example, how to make people trust science and comply with public health policy?
Those are awesome questions and incredibly important. And a lot of people are working on them. We have much more work to do. And I think the human dimensions and the psychological aspects and how do we get the whole society to work for a collective good is an interdisciplinary approach that takes all of us. So a lot of what we've had driving, the data-driven innovation I've done is really focused on the data and the quantitative, and you serve up the information. But you're very right, it doesn't stop there. You take the information, people have to adopt it, or they're going to interpret it different ways. And how do you get that information to translate into behavior change and all of those many important things? I do not have a clear answer. I don't have an easy answer. I do know there's no silver bullet and that there are thousands of people working on this, but what I've seen be most effective is one-on-one connections and small, the small impact with trusted people. So if you have a doctor friend and you've known them for 30 years and they say the vaccine is safe, that's going to go a really long way compared to, a stranger on TV. So I think it really comes down to we need all disciplines, but we also need all of us, and listening to each other, doing it with an open mind, truly hearing people's concerns, and then hopefully serving up information as we have it, as we know it, and if we don't, be honest about it. The science hasn't figured that out yet. And then little by little, with repeated engagement, hopefully build trust. And in the data world, I always say change can only happen at the speed of trust. And I think of trust as consistency over time, and keep showing up. You need to consistently show up and have positive engagement over and over and over again. And consistently showing up can mean working in the open. Just keep showing up, keep being there, even when it's tough. And we found that in COVID. Sometimes things are acrimonious, sometimes there's differences. We found it in Lyme disease. The Lyme, in the scientific uncertainty, there's two different sets of medical guidelines. And sometimes insurance will deny care because they did it on one guideline, not the other. And patients fall between the cracks, but they're still sick. And then science and medicine not helping people, they fall between the cracks. There's anger, there's animosity, and it can be hard to lean into that. It can be hard to sit at that when you're being yelled at because your government or your science, you're part of the problem. And with my team, we try to say, keep showing up, listen to people, even when it's hard. And then if you are truly there with an open mind, present, hopefully together we can move through the anger, move through the whatever it is. And oftentimes the patient perspective, the lived experience, the on the ground is a wealth of information. So if you're open enough to hear it, it should be two-way learning, and we'll both learn from each other, even though it's uncomfortable at times.
Thank you. It
With
was
that,
a great answer. Yeah. Thank
With
you,
that,
Dr. Kristen. Yeah.
I'm sorry. Okay. With that, we've gone a little bit over, but this has been a fascinating discussion. I think you've, Dr. Honey, I think you've approached the correct audience. I think this is exactly the audience that have a part to play in this. We're all public citizens. We all have a role. And let's do our thing. Thank you very much for your presentation.
Yeah, COVID response is a team sport.
Renwar,
do you have anything to add?
No, thanks, Dr. Kristen, for your presentation, and thank you to all the attendees for the questions and interactions during the session. And please provide your feedback using the form that I'll be provided just within a minute in the chat box. And thank you again, everyone, for joining today's presentation. And I hope you gain some insights from this session. Hope a wonderful rest of your day. And thank you for being part of this year's DataCon LA.
Thank you so much. Bye-bye.
Thank you very much.